Hi everyone, welcome to Pulmonology Read Aloud. Today I'm back with the part 2 of Bronchiectasis series. This one is Airway Clearance Techniques in Bronchiectasis published in the ERJ and the ERS 2017 Guidelines Takeaways. If you're new to my channel, please subscribe and join the channel for regular updates on everything pulmonology and more. So in 2017, the European Respiratory Society published a statement on airway clearance techniques in adults with bronchiectasis. Now, this statement was very important because airway clearance techniques has been established to be an essential strategy to control the symptoms of our patients with bronchiectasis and to improve the mucociliary clearance. So now if your patient of bronchiectasis is only on medical management, it is likely that his symptoms will stay uncontrolled unless we help him clear out the excessive mucus. And so it's important to address airway clearance in each of our symptomatic bronchiectasis patients. The guideline committee that was used to make these guidelines included a multidisciplinary group, and this included not only pulmonologists but surgeons, physiotherapists, patients as well. These recommendations were based on preliminary international data that suggested that clinicians' recommendations in ACTs or airway clearance techniques were highly inconsistent. This was also because of lack of knowledge, lack of implementation, and so these guidelines are kind of a benchmark paper that tells us how to set quality of care in patients with bronchiectasis. These guidelines, however, are applicable only to patients with symptomatic bronchiectasis. So, a patient must have a radiologically diagnosed bronchiectasis with permanent bronchial dilation and should have clinical symptoms, which includes cough, sputum, and repeated respiratory infections. They clearly indicated that the guidelines do not cover patients who are asymptomatic and may not need ACTs, patients with cystic fibrosis, which is a totally different group, children and adolescents for whom another set of guidelines were later on released, patients with immunodeficiencies and NTM infections. Here, all those patients who had radiological bronchiectasis but did not have clinical symptoms were not addressed. What is the rationale of doing airway clearance in a patient with bronchiectasis? Now it is known that patients with bronchiectasis, when you evaluate the sputum, then it is more hyper concentrated and more dehydrated, and actually the level of mucin concentration in the sputum is related to the severity of the disease. This indicates that the level of the mucus layer dehydration also plays a very important role in pathophysiology of the disease and the clearance and the mobility of the sputum in the airways. So when we use mucus clearance techniques which give mechanical stress, which could be in the form of fluid shear stress, which could be because of the compression, because of stretching, oscillations, vibrations, osmotic shocks, they all help to enhance the expiration and the expiratory to inspiratory flow rate and the volume of air that reaches behind these lung regions that are obstructed by mucus, thus mobilizing. So ACTs have a huge role in the way the secretions are mobilized. There are a lot of advantages to these techniques that have been enumerated as per the guideline statement, and these include improvement of the collateral ventilation, increasing the expiratory airflow velocity for the patient, using gravity, percussion, pressures, changes in airway oscillations to achieve a peak oscillation and a sustained oscillation that can bring about airway clearance. The one more advantage is that this can be performed by the patient. So it may not require a physiotherapist always, because there are devices that the patients can do themselves. The only limitation being the need for cleaning, disinfection of these devices, and a lot of care and precision. Now, the type of ACTs that are used worldwide mostly include: number one, the active cycle of breathing technique. So, if you ask a physiotherapist about chest physiotherapy, the first and the foremost airway clearance technique he would mention would be ACBT. So, ACBT is a very, very important ACT. The other is positive expiratory pressure, which could be oscillatory or non oscillating, techniques that are based on gravity, and we know about manual percussion as well. If you look at this chart, which looks rather congested, you see the list of the major ACTs that have been studied over time, and the guidelines beautifully mention the various findings of various RCTs and trials on them. Most include forced expiratory technique, ACBT, the manual percussions, the manual vibrations, the gravity dependent drainage techniques, the high frequency oscillation techniques, the intermittent pressure ventilation techniques, as well as techniques wherein the patient is asked to expire through a closed glottis, the huffing and puffing, and positive expiratory pressure techniques. So these techniques and the PEP therapy and the PEP devices together compromise most of the ACTs. This is a beautiful chart taken from the guideline statement, which tells us about the clinical use of the airway clearance techniques amongst various studies across the world. Now, if you look at these graphs, they represent the ACTs that have been most commonly used worldwide. Right? So here, if you look at therapies like ACBT, almost all across it has been widely used amongst major papers. For gravity dependent techniques, there have been lesser numbers as compared to ACBTs. There have been also an equal share of autogenic drainage of PEP as well as PEP masks. The gravity dependent techniques, which are presented mostly as the postural drainage in the studies, has been extensively studied in some of the studies, like the one by O'Neill et al. And most of these studies, if you look at, they have looked at a combination. So none of this would be 100%, because most patients would require a combination of some of these techniques. So if you look at the percentage of physiotherapists who were using a PEP mask versus a PEP mouthpiece, a PEP bottle, or a flutter, or a gravity dependent technique, it would usually not add up to 100% for a single technique, telling us that most of these techniques have to be used together or interchangeably in our patients. Shifting slightly away from the guideline statement but concentrating on the message from the guideline of the ACTs, when we perform airway clearance, we can use physical aids or pharmacological aids. So, pharmacological aids, which are our mucolytics, can also help with the physical aids to help clear out the secretions. So in physical aids, you could have the breathing techniques, the mechanical mobilization by PEP or oscillating PEP devices, and the assisted chest physiotherapy. Since our training in respiratory medicine, we've all heard about the postural drainage, which is one of the most commonly taught technique for drainage of various lung segments, especially in bronchiectasis, with the cupped hands and the percussion in the respected segments. But since this is a technique where patient cannot himself perform airway clearance, a lot of airway clearance techniques have come up where the patient can be educated on how to do. So one of this, as I said, is the ACBT. The ACBT, or active cycle of breathing technique, consists of three main phases. In the first phase, there's a breathing control, where patient will gently breathe through his lower chest. After that, when he's relaxed his upper chest and shoulders and is breathing with the lower chest, there will be a cycle of deep breathing. Here the patient is asked to take slow, deep breaths, hold his breath for 3 seconds, and do a relaxed breathing out for 3 to 4 deep breaths. Once done, the last stage of ACBT involves huffing or forceful expiration, where patient has to half breathe in and follow with a fast breath out steadily through an open mouth, using the muscles of the chest and stomach to force the breath out. So by using a combination of these 3 phases, patients can effectively mobilize their sputum, and this cycle can be continued, and several ACBT cycles can be done by the patient. These are the various PEP devices that are available, and this figure is not from the guideline statement, but I've added it so as the audience knows what we're talking about. This is one of the most common one, the acapella, which is color coded for different purposes, though not very easily available, with a lot of difficulties in cleaning and disinfection. The newly available in India and available all across, the Aerobica from Trudel, Flutter, which is really popular, RC Cornet, something that I have personally used in my patients, the Sure Clear, the Lung Flute, which is also very common, Pocket PEP, Vibralung, VPEP, and VibraPEP. But a lot of these PEP devices have common problems of cleaning disinfection. Some of them don't, like the RC Cornet and the Aerobica. And I'll just be briefing about them so that when you prescribe them to your next patient, you know what exactly is the job that they will be doing. So the PEP devices, basically how they function is that they use a counterweighted plug, and there is a short metallic strip that gets attached to a lever and a magnet. So because of that weight, a counterweight and a lever and a magnet which is moving, there is an expiratory pressure produced. The oscillating airflow can be initiated once the patient starts exhaling through the interface, and then the magnetic field can intermittently occlude the passing airflow and provide resistance. And there are a lot of these which have a dial where you can change the level of resistance. If you look at the Acapella series, they have a green version which is intended for those patients whose expiratory flow rate is higher, more than 15 liters a minute, and the blue version, which is for people who have a lesser expiratory flow rate, so a lower amplitude of vibrations compared to others. So by changing the amplitude of vibrations, by changing the mechanism of the oscillating airflow, various devices can help with various levels of resistance in expiration. This is what a flutter looks like, and if you look at the figure inside, you can appreciate the circular cone, a high density weight, a steel ball here, and when the patient exhales, then because it's shaped like a tobacco smoker's pipe, it's a small device with the mouthpiece very proximal to the user. So with this high density steel ball resting in an annular cone, with expiration, the approximation of the circular cone and magnet changes the kind of resistance that is available when the patient expires. The flutter valve actually works on the oscillation of this conical ball, and once expiring, the ball successfully enlarges and closes the gap with the support cone. So this way, whenever the patient takes out the mouth to inhale and then exhales, there is a variation in pressure and there is an oscillation, and this is the way that a expiratory pressure is produced, causing mobilization of mucus. The flutter is a gravity dependent device, and so when the patient holds it at different angles, it affects the effort that he requires to initiate the ball vibrations. So in this way, a graded variation can be given. However, because it's a gravity dependent device, there's a lot of times where the patient is not able to generate the required pressure, and therein lies the disadvantage of this device. The Aerobica or Trudel is a new device a compact, a handheld design, which really gives a lot of advantage when we talk about cleaning of the device, assembly and reassembly of the device. And here the patient exhales via its mouthpiece against a manually adjusted resistance, which we can change from the outside, which is housed by a valve in the cartridge. And this works well for patients who can vary their resistance, and non-gravity dependent, it can provide the oscillating PEP. Lung flute is a very commonly available device which resembles like a flute like instrument, and here it's not the periodic airway occlusion. um, it operates on an acoustic energy by vibration of the reed inside the device, which works with the exhalation. So whenever a patient exhales with a minimal force, a sound wave and acoustic frequency is produced, and this is what generates the expiratory pressure. But the problem with this device is that the reed has to be replaced almost every 2 weeks depending on the frequency of use, and the whole disassembly and washing has to be really careful. Argiconate is another German device that is available. I've used it on a lot of my patients. It's quite beneficial, where an adapter has been given which contains a valve. It's attached to the mouthpiece, and you can also nebulize the patient, giving them PEP therapy with it. It also has various resistance settings, and when the patient expires, an OPEP waveform is produced, which creates a end expiratory pressure. Now, this is also a gravity independent device, so works well whether your patient is lying down or sitting, and can be used in all of these conditions. I'll quickly now go through the main takeaways from the ERS 2017 guidelines for bronchiectasis management. Much of this has a lot of overlap with the BTS guidelines for bronchiectasis, which I have taken up in the first part of this series, and I'll be linking them with the video here. So much of this is an overlap, but let's just quickly take home what the ERS guidelines talks about. So the first question that the ERS guideline caters to is regarding testing for bronchiectasis, and whether we should have a standardized set of tests or we should not have a standardized test and do individual testing. So the guideline statement clearly indicates that you should have a minimal bundle of tests in all adults, which include a differential count, which include the serum immunoglobulins, and you test for ABPA. Obviously, if you have a patient which is suspected of NTM or which is suspected of repeated infections, a sputum culture becomes very, very important. The second question that the guideline looks into is the question of antibiotic therapy, and whether 14 to 21 days of antibiotic therapy should be given for every exacerbation, or should we treat patients for shorter courses for adult patients with exacerbation. So the guideline committee recommends that all acute exacerbations should be treated with around 14 days of antibiotics, but this is a conditional recommendation. It's not a strong recommendation. This means that you may not need a 14-day of antibiotic course in all your patients. So this varies, because if you're dealing with patients with Pseudomonas infection, you would want to treat them for 14 to 21 days. But if it is another infection, say a strep pneumoniae infection, which responds beautifully to antibiotics, you may actually achieve the same at 7 days. So there have been a lot of studies that have looked into this, and they've documented even good clinical outcome with shorter regimens in certain infections, and no direct evidence of benefit of 14 to 21 days course of antibiotic. So hence they also mention that it has to be really based on the patient. It has to be based on what kind of profile of patient and what kind of infection that we are looking at. So the justification that they've given for this recommendation is that they do not have any direct data comparing longer and shorter antibiotics. So till the time we do not have direct data, you continue using 14 days of antibiotics. But having said that, if it's a mild patient where it's a pathogen which is very sensitive, you may actually do well with a rapid return to baseline state with a shorter course as well. The third question that the guideline looks into is eradication treatment for bronchiectasis with any new isolate of a pathogenic microorganism. Now, this, just like the BTS guidelines, makes it really clear that those patients who have a new isolation of Pseudomonas have to be offered the eradication protocol, although it's again a conditional recommendation. And if it is not a Pseudomonas infection, then it will not be offered. So eradication will not be offered. Now, again, this comes in view of the definition of exacerbation, and the most frequent definition which is used in bronchiectasis studies for eradication treatment is that two or more isolates of the same organism have been reported at least 3 months apart in a year, and they've taken those patients for these studies, and these recommendations come from them. So, unfortunately, when you look at patients with persistent infections, there's not much evidence about beneficial effects of eradication beyond Pseudomonas. So, studies are mostly looked into Pseudomonas, they're mostly looked into two or more isolates in 3 months, and that's why they say that a minimum that patients must have is when you're giving an antibiotic treatment, they must have sputum clearance. So you must keep sending the sputum and rechecking whether there is an eradication of the bacteria. But for Pseudomonas, they definitely recommend that there should be an eradication attempt, and but for even for Pseudomonas, they do not address the point where they have a Pseudomonas infection persistent for many years beyond eradication. So that is why the recommendation is conditional. But in the current scenario, Pseudomonas, yes eradication; non-Pseudomonas, no eradication. Coming to the next question, number 4. Should long-term anti-inflammatory agents be used in bronchiectasis? This was again addressed in the BTS guidelines. You can listen to that video. So they also recommend not offering treatment with inhaled steroids in bronchiectasis just for bronchiectasis because there are no large trials of the same. They are recommending that there should be more RCTs on inhaled steroids in patients who are naive to inhaled steroid therapy, but they also acknowledge the fact there are hardly any patients, there are very few patients who've never been given inhaled corticosteroids during the course. So they recommend that you should not offer it if it's not needed. If it is a patient of COPD, you would have to give it. And again, for statins as anti-inflammatory, it is not recommended. Question 5 is long-term antibiotic treatment more than 3 months compared to no treatment beneficial. So here again the criteria is 3 or more exacerbations per year. So if your patient has 3 or more exacerbations per year, that's when long-term antibiotic will be considered. And here again, if it's inhaled antibiotic that you're considering, it exclusively goes to chronic Pseudomonas aeruginosa infection. If your patient with chronic Pseudomonas aeruginosa infection does not tolerate inhaled antibiotics or it's not possible, then you would give long-term macrolides. If your patient with Pseudomonas aeruginosa infection has infection repeatedly despite inhaled antibiotics, you would add a macrolide. Or for patients who do not have Pseudomonas infection, you would give macrolide and not inhaled antibiotics. And this choice could also be based on the drug sensitivity report. So sputum testing becomes more and more important, and you would use inhaled antibiotics only if the patient is not getting better or not tolerating the oral antibiotic prophylaxis in non-Pseudomonas population. So this is a chart which is taken from the ERS guidelines. It very well depicts that if you're more than 3 exacerbations, you optimize the clearance. If it's Pseudomonas, you give long-term inhaled antibiotic. If it's non-Pseudomonas, you give long-term macrolide antibiotic. You can add the two if it's non-responsive, or and combine it, and or give a long-term targeted antibiotic based on the sensitivity. Another flowchart answering question number 6 on long-term mucoactive treatments more than 3 months. So we usually start with, we offer long-term mucoactive treatment if your patient has a difficulty in expectorating sputum and he has a poor quality of life and the standard airway clearance technique. So again, airway clearance techniques are so very important. If they have failed, then you give a longer mucoactive treatment. So you may, in such a case, in an exacerbation, give a shorter long-acting bronchodilator, a mucolytic, a physiotherapy of airway clearance, and antibiotics if they persist to have a infection. So individualized treatment is the key here, and based on the sputum viscosity, the bronchial hyperreactivity, but they need larger studies to establish a rule. Question 7, is long-term bronchodilator treatment compared to no treatment beneficial? There is no evidence to support bronchodilators routinely. If he is significantly breathless, you can give the appropriate long-term bronchodilator. Are surgical interventions beneficial as compared to standard non-surgical? So if you have a localized disease, patient is having repeated infections and exacerbations, despite all optimizations, you take him up for surgery. So it has to be a carefully selected group. And whenever we think about taking a patient of bronchiectasis for surgery, it's very important to undermine the fact of preoperative nutritional status and optimization with rehabilitation so that the outcome of surgery is better. The last question of this guideline talks about regular physiotherapy, airway clearance, more beneficial than control, and the whole paper that we discussed before this answers that question. So if your patient is symptomatic, you would ask him for regular airway clearance. It's a common belief that physiotherapy can not only improve mucus clearance but also reduce lung inflammation and risk of infection. And physiotherapy is very well accepted by patients, so the ACTs and the pulmonary rehab can be given to the patients, must be given to the patients, and advised in all your symptomatic bronchiectasis patients. And the evidence here is weak because the studies are small, but with more and more evidence which is coming out in terms of exercise capacity, in terms of cough symptoms, quality of life, reduced exacerbations, and the benefits of pulmonary rehab, with the research coming up, more and more role of regular physiotherapy of patients is coming up. So with that note, I end this video, and I encourage you to visit my channel, look at all the other videos, and happy reading, and keep liking, subscribing, and sharing because that really matters for me. Thank you so much, and see you soon.